Good evening. Thank you for being here with us today. We have already muted your microphone. If you have any question, you can write on the chat. Now I announce Canada-Taiwan Future Healthcare Forum starts. First, let me briefly introduce myself. My name is Liren Chu. I'm the Canadian delegate of the Global Taiwanese Medical Alliance. I'm the host of this forum. Global Taiwanese Medical Alliance, the abbreviate is GTMA, was formed on January 5th, 2020. It currently has 95 representatives from 24 countries, linking the global partnership with Taiwan in the medical and health professionals and industries. The GTMA's mandate is to combine the medical and health professionals and industries from both within Taiwan and those residing globally to respond to the UN Global Sustainable Developmental Goals and to promote global health. The GTMA is therefore committed to promote Taiwan's representation in the UN's World Health Organization, WHO, and its joint vision of health for all. Today, we bring together experts, professionals, and entrepreneurs in healthcare technologies from Taiwan, Canada, and the US. They will provide diverse insights in universal healthcare systems between Canada and Taiwan. The forum especially emphasized the efforts in coping COVID-19, artificial intelligence, and digital technologies, and the opportunities to cooperate between Canada and Taiwan. We hope to work with experts, investors, and entrepreneurs from both countries to find AI and digital solutions to help cope with healthcare challenges during post-COVID-19. Before we move on to the forum itself, I would like to thank our guests and organizers to send us their greeting videos and their support. We will share their videos at the end of the forum. Our guests include Canadian MP Honorable Don Davis, Taipei representative of Taipei Economic and Cultural Office in Canada, Mr. Wen-Yi Chen, Director General of Taipei Economic and Cultural Office in Vancouver, Mr. Andy Chen, Deputy Director of Taipei Economic and Cultural Office in Vancouver, Mrs. Suzy Chen, Director of Taiwan Trade Center in Vancouver, Mr. Frank Chen, President of the Global Taiwanese Medical Alliance, Dr. Peter Chang, President of National Taiwan University Alumni Association in Vancouver, Dr. Liren Chu, President of Distinguished Citizen Society Headquarters, Mrs. Xiumin Jian, President of Distinguished Citizen Society in Vancouver, Mrs. Patty Chan, President of Global Federation of Chinese Businesswomen in BC, Mrs. Susan Cho. Our panelists include Dr. Kendall Ho, Dr. Jieshi Kang, Dr. Jack Lee, and Dr. Jinghui Ji. They are world leaders in this field. Let me introduce each one of the panelists before we start. And please, if it is possible, spot on each one of them. The first one is Dr. Kendall Ho. Dr. Kendall Ho is professor and academic director of the UBC Community Health and Wellbeing Cloud Innovation Center. The second one is Dr. Jieshi Kang. Dr. Jieshi Kang is professor and director of AI and Robot Construction Lab in the University of Alberta. He is also CEO of Jubo. Jubo is a company for integrated technologies for senior care. The next one is Dr. Jack Lee. Dr. Jack Lee is a medical doctor and is distinguished professor of Taipei Medical University. He is also president-elect of International Medical Informative Associations. Then is Dr. Junhui Ji. Dr. Junhui Ji is professor and director of Oregon State University Center for Global Health. Now I would like to move on to the forum itself. I will moderate the first part of the forum. Dr. Peter Chang will join us later. The sequence for each presentation is, the first one is Dr. Jack Lee, then Dr. Jieshi Yang Kang, then Dr. Kendall Ho, then Dr. Junhui Ji. Now, I would like to invite our first speaker, Dr. Jack Lee. Dr. Jack Lee, are you ready for presentation now?
Yes, yes. Thank you, Dr. Chu.
Okay.
Okay. So I'm gonna share my slides. Okay, can you see my slide?
Yes.
Okay. Okay. So in the next 10 minutes, I would like to share a little bit of the insight on the AI or artificial intelligence for the post-COVID-19 healthcare. Let's see if I can. Okay, so that's a bit about myself. I'm a dermatologist. I'm also a full-time medical informatics professor, also the president-elect of the International Association for Medical Informatics, or IMIA. So this is, IMIA is kind of a worldwide organization that has about 60 member countries. We actually wrote a letter to WHO in April for the recommendation that IT and AI should be used to fight the pandemic. So there are 4 major points in the letter that the first point is that we have to be preemptive. We need to use AI to predict and then prevent things from happening. So in Taiwan, we call it 超前部署, or just do everything early. And early is very important this time, and most of the time. The second thing is to use telemedicine universally. Like you've seen growth in telemedicine, it's the extraordinary growth of telemedicine use in the US and the rest of the world. The third point is to share data in order to create big data, because AI needs big data. If we have, AI is as good as its data. So if we can share data across different countries, then we'll end up with the most useful big data that we can use to fight the pandemic. The last thing will be transparency. Of course, the whole disaster was caused partially by the lack of transparency from some of the countries. And we still have lack of transparency from some of the countries, and it's not helping. And my personal recommendation for this post-COVID-19 healthcare, and actually we're not post-COVID-19 yet. We're kind of in the middle of COVID-19, but everybody's envisioned a future, and the future is also now, that the healthcare should be changing in order to carry on the important mission of promoting better health. So my first recommendation is that in healthcare we need to be early and earlier. Like we need to use AI to do disease prediction, because the most effective way in preventing a disease is to predict it accurately. If we cannot predict a disease, we cannot effectively prevent a disease. And also for disease screening, there are a lot of debate about how much resources should be spent to screen the whole population for COVID-19 this time. And my take on this problem, on this question, is actually we should use AI to do disease screening, and we test on people with the highest risk. Not everybody, but we test more people, but these are already been determined high risk by the AI through the data. We can call it digital screening, smart screening, or we can call it dry screening. Meaning before you actually put a swab into your nose, we have the AI determine your risk. And it also applies to diseases outside of COVID-19, of course, or even infectious disease. Also, AI for disease monitoring. A lot of disease you need constant monitoring. AI for disease progression and also microprogression. For example, if you have a pressure injury for long-term patient, you look at a pressure injury or bed sore every day, and human cannot tell the minor difference day by day. Although after a week you will know, but in order to look at the micro change, AI could really help. And also AI for prognosis and mortality prediction. You can see papers like this like every day. And also AI for prediction and prevention of disability. So AI is not just used to predict disease, also to predict disability. And the reason we want to do that is we want to prevent disability. For example, if the patient is a high risk for falling, then we should predict that and then prevent that so that the fall did not happen and the fracture did not happen and the disability will be prevented. The second recommendation, besides early and earlier, is that we should do healthcare in place. Okay, I think some of you have heard about aging in place, but we cannot have aging in place if we don't have healthcare in place. And you have seen the power of telemedicine or telescreening, teleconsultation, teleintervention, and telemonitoring. So you can tell everything that you don't need when you don't need to see a doctor physically. And we haven't actually done that. I mean, the whole world haven't actually done that. But this time, this COVID-19 really is a driving power to let us realize that the technology is already there for years. It's just the habit of the patient that we cannot, that we did not accept telemedicine and teleconsultation as a whole. But now it's much better. Actually, in Taiwan, the last 6 months, the first 6 months of this year, our whole visit to the doctor, the number of visits to the doctors has been reduced 16 million times. Okay, only in Taiwan, 16 million. I'm not getting it wrong. It's 16 million. Okay, only in the first 6 months. So that can be transformed into telemedicine potentially. And the third recommendation is we need to use AI in every detail of the healthcare process. So we have to be smart in every way. AI has been used in radiology. You've seen examples of AI recognizing CT images, brain tumor, lung cancer, and stuff like that. But actually, AI should and can be used in ER, emergency room, the outpatient clinic, inpatient clinic, ICU, operating room, etc. You know, every detail, every place in the hospital should be infused with AI. So we've seen AI used in images, right? A lot. Now there's another breakthrough called GPT-3 from a company called OpenAI that we're going to have another breakthrough on text recognition, or text understanding, or even text generation. You might be able to imagine a day that the whole chart is mostly completed by AI. You know, our nurses and our doctors spend 20% or more of their time doing charting, meaning typing, you know, this data from data and description of the patient. Now AI can do it. And we also use AI for biosignaling codes a lot, especially in a universal healthcare system like Taiwan and Canada. We tend to have much better codes for our electronic health record, and we have a much better standardized codes as well. So we should take advantage of these codes. Typically, in the past, we use traditional statistics on these codes, okay, which we have a lot of results. But now we use machine learning and AI to deal with the codes, we're much more flexible and we're much more capable of handling high amount of variables, like thousands of variables at the same time. So it actually gives us a new possibility, which is the potential is immense. We use AI for caregivers a lot, meaning you see product that's customized for that's provided for the hospitals and the care provider, physicians, nurses. But I think the most potential will be AI for patients. Although we have not seen much now, but I think we should use AI for patients because it's the earliest, because it's the first stakeholder that the healthcare system is. So if we give good tools to the patient, then we reduce the cost in the end of the system. So I propose something called early medicine, and if you're interested, you can look up the paper in JMIR, Journal of Medical Internal Research. We just published it last month, a few months ago. So I think we need to. So we need to do this early medicine for, it refers to temporal and predictive and proactive approach to individualized health. I think the key word is individualized health. And in a country like Canada and Taiwan, we have the most potential and we have the most capability and the big data to do this. Not every country in the world are ready to do it right away, but I think Canada and Taiwan are two very good examples that we can actually do it. So this is one example that we could put the AI tool in the hands of a consumer. This is called MoMe. You just answer a few questions, and then you you take a picture of your mole or nevus, then it will tell you the risk. This is the palm of my son, and he has something. He has a small mole on his palm. And he's actually a little bit of worry about it. So we use this tool, and it's low risk, so he's quite happy about it. Oh, something is stopping me. Okay. And this is another patient. This is actually a 19-year-old boy. So his mother brought him to our clinic and said, this is a displaced nevus. We did a biopsy, and it's actually a premalignancy. So we removed it, and the mother was very happy. So she actually brought all her boys to our clinic. This is a young girl, and the AI determined that this is higher risk. And she came to our clinic. We did a biopsy. It's actually a stage 0 melanoma. So she was very happy that we discovered the melanoma as early as technically possible. This is melanoma in situ. This is, of course, too late. This is an 80-year-old female. She resists to see a doctor, but when she came, it's very late. Okay, so I think this is another example that we use deep learning and machine learning to predict non-melanoma skin cancer. And we also use it to predict a lot of other cancers. So now we know with machine learning and big data, we have the capability to predict cancer in the next 12 months. And since we can predict it, we can prevent it in an individual fashion, because everybody has a different risk of different disease and different cancer. So that's why I think we should, the current medicine is focused on treatment, which is very expensive and more burnout. And it will eventually lead to a collapse of the healthcare system. So I think we should use AI, and we should promote early medicine that we end up with lower costs and better outcome, and more sustainable healthcare system. And I think the best opportunity lies in countries with universal healthcare, because we have more structured data and more standardized data in place. So I think that the AI has to change the future of medicine, because if we don't, we may not have a future. Thank you.
Jessica.
You're muted. Oh, okay. Yeah.
Oh. Thank you, Dr. Jack Lee. Our next speaker is Dr. Jessie Kang. Dr. Jessie Kang, please.
My screen?
Yes.
That's perfect. Can you see the screen now?
Yeah.
Okay, good. Hi, everyone. My name is Jesse. I have actually two roles, one in Canada and one in Taipei. Now I'm the professor in University of Alberta, and also I'm the founder in a startup in Taipei called Jubo.health. So today I'm going to present the ideas by the two roles, combining the two roles, one in Canada and one Taipei. So I want to start it from introduce a little bit what we are doing and who we are, and I have some insightful thinking thoughts about what we can do together between Taiwan and Canada. So the goal of Jubo is to connect the cares. We all know that in the care environment, in the care loop, there are senior people. They are caregivers. They are the families. There's actually a group of people in the environment. And what we are going to do is to connect the caregivers, seniors, and the families. And I want to start it from a little bit the background of our team. I started as a professor in National Taiwan University in 2009. When I started, actually, as my early career, I started as an assistant professor. But at that time, we have a chance to go into the so-called smart aging research, smart aging studies, focusing on the senior aging society in Taiwan, the society in getting aging. So we started as a research projects, and in 2016, the project become a interdisciplinary research project, and the goal is to develop tools and to facilitate the problem on long-term care. And then in 2018, we start Jubo, and 2019, we launched our first product in long-term care facilities, and 30 plus facilities using our system. And this year's the market grew to 100 facilities, and now we are expanding the office to Vancouver, and this is a new step. The next year will be the new step of the company. So just give you the ideas of what we are doing and what we plan to do. And then I want to go back to Taiwan and Canada, because we are kind of across the country looking to the same markets, which is long-term care facility markets. And we found that there's a lot of similarity between Canada and Taiwan, of course, a lot of differences. So today, the population, aging population is, Canada is almost twice as Taiwan, and the population between Taiwan and Canada is about 1.5 times difference. But now there are two interesting numbers. One is the aging ratios in 2019, which is 70%, but 16% in Taiwan. But after 10 years later, so the population, the ratio, aging ratio will be similar, Taiwan even higher than in Canada. So, but in terms of the care facilities, Canada have the facility can accommodate about 200,000 senior citizens, and Taiwan only 10,000. And but the number of the number of the facilities is in Canada is slightly smaller than in Taiwan. So that shows the Canadian long-term care facility is larger in every facility. So that's kind of give you the idea, just some similarity, but a little bit differences between the two countries. And now I want to go into the post-COVID, the issues under the post-COVID-19. You see the deaths tolls in Canada. 80% of the deaths occur in the long-term care facility. So that means a lot of work need to be done in the long-term care facilities. And there's even there's also another two numbers. One is 182 long-term care facility have more than 10 deaths, and the 5 nursing home even have unfortunately 40% of the death rates. So that's one thing very serious in Canada, especially in the long-term care facility. But the problem is not only the threats of the disease, but also the another mental issues. Loneliness is a big issue now. It's actually an issue before the COVID, but it's getting worse in the during the COVID-19. So here you see the social isolation make loneliness problem even worse, and especially for the aging population. And then the loneliness issue is even worse because of the social distance and the limitation of the visits from the family visits to the long-term care facility. So the issue is getting worse because of the pandemic, and then the pressure and the anxiety is also increased, shown by many different statistics and the research. So during the COVID-19, you see the increasing pressure and anxiety significantly increase. And now I want to go back to what we are doing and what we can do a little bit about to reduce the problem in the long-term care facility. And this is our goal in Jubo. Jubo is a network, is a smart network to connect the people and reduce efforts in indirect care. Here you see in a long-term care facility, the direct care only 40% of the nurses' time, but they spend a lot, about 60% of the time in the indirect care, so including writing the nursing record, communication, and administration. So we try to upgrade the tools. So now you see most of the tools in nursing home is a computer, telephone, and some paper-based records, and then put in all the numbers and print out the statistics results and call if there's anything wrong. So that's something we can leverage by the new technology. So this is a solution we provide from the bedside IoT measurements and direct to the cloud, and by the family chatbots or the chatbot between the caregivers, the nurses, and so reduce the time for the communication. And also a nursing information system. There's some AI inside the system to reduce the time of writing the paper. So our belief and our idea is in the future, only the direct care need to be done, and a lot of paperwork and the communication can be automatically transferred in the internet. And we also developed the long daycare center solutions, now running in more than 15 daycare centers in Taiwan. So that's the solution we provide, and we get some good feedback from the users. Now we have a 10% market in Taiwan. Even outside Taiwan, we have one daycare center in Penghu using the system, and now 1.4 million nursing records. So as Dr. Jack Lee just mentioned, the AI is super important, but the data is even more important before having the AI. And we found the augmented communication with the families is the true value of the system, especially in the COVID-19 time. So it's including in the system, and the whole system reduce the paperwork time and increase the interaction between resident and caregiver. Hopefully, this also reduce the problem of loneliness and the higher family engagement. And now we are moving toward the next step, which is Canadian markets. We all see very similar problems between the in the Canadian long-term care facility with Taiwanese long-term care facility. One is overwork staffs and forced isolation of the patient from their families and the limited in-person interaction to reduce the infection rates. So the same problem, and we kind of, but a little bit different environment. So we need to twist our solution a little bit. So for example, we use Line as a communication tools. We develop chatbot in Line, but in North America, maybe WhatsApp is or email, text is the channel people communicate. So we are developing, or we are transferring our solution and working with the EHR solutions companies called Point Click Care, and we are integrating our solution with theirs, and hopefully we can provide some better tools for the long-term care facility, increasing the communication between the families and the elderly in the facility. And we are building a team, and the team is one team. Actually, the team located in two places: one in Taipei and the other in Vancouver. So the team is we start working the team almost 3 months from now, and then hopefully next year we will have our first product launch in Canada. And I wrote several articles introducing Canadian markets, introducing the Canadian long-term care facility, and even the use of technology in a Taiwan magazine. It's called Anchor Tranmei, which is from my point of view, which is the best press on the long-term care. Hopefully, if you have a chance to look into the article, and then feel free to give me some comments. So this is one article I wrote in September, just published, and this is another article talking about the Canadian daycare center and how the Canadian daycare center taking care of the multicultural and also use of the technologies. So this is about my presentation. Now I'm kind of working in both locations, one in Taipei, one in Vancouver and Edmonton. And hopefully we have a more discussion if you happen to, like me, to have a 2-location working style, and let me know, and hopefully we can work something together. Thank you very much.
Dr. Ting. Our next speaker is Dr. Kendall Ho. Dr. Kendall Ho, are you ready? Do you need my help with the PowerPoint?
Yes, I'm ready, and I'll see if I can share my slides with you. Now, hang on a second.
Do you want my help? I have your slides here.
Yes, I think. Can you now see my slide?
Not yet. Oh, okay. Yes.
You can see now?
Perfect.
Okay.
Yes.
I'll put that in presentation mode. Hopefully you can see that too. Can you see the presentation mode now?
Yes.
Excellent. Great. Well, thank you very much. It's my honor to participate in this Canada-Taiwan Future Healthcare Forum. Really want to thank Professor Chan for inviting me. And also, I feel very honored to follow both Dr. Lee and Professor Kang. Just tremendous opportunity to look at this area. And I think I am an emergency physician that works in Vancouver. I'm also a professor at UBC Faculty of Medicine. And finally, I'm the academic director of the Cloud Innovation Center. How do we leverage cloud computing for community well-being and health? And so in those roles, I'd like to just explore in the next 12 minutes or so about universal health coverage, COVID-19, and how the technology transform some of the ways that we deliver care in British Columbia, and what might be some of the partnership opportunities in those areas. I'd like to give you a bit of context about British Columbia. I presume many of you have been to British Columbia, and if you haven't, I'd love to have a chance to welcome you here. British Columbia is one of 10 provinces and 3 territories in Canada. Our surface area of our province is about 26 times that of Taiwan. Yet in terms of population, we have a total population of 5.1 million. And in fact, if you look at that map there, the Vancouver dot has 2 million people there. This is about 1/5 the population of Taiwan. And so the type of delivery of services for us is going to be in many ways similar to Taiwan in the sense of publicly funded, but also in many ways different in terms of the population delivery. And so we think about the tenets of universal healthcare: health for all, equity of quality access, and also to have the spread of primary care to coordinate care services for patients. One can see that there are similarities and differences that we have. And indeed, when we look at the gap of British Columbia, some of the challenges that we have in universal health coverage is that there's a difference between urban, if you live in Vancouver, compared in regional, such as the capital of British Columbia, Victoria, or Kelowna, to rural locations. If you think of some of the remote locations on this particular map, that there will be differences in delivery services. There's also, especially in the emergency department, where if you think about it, it's really the safety net of the health system to support patients with unexpected emergency crises. And so in that sense, delivering that urgent care and think about how to deliver it in an urban center compared to in a rural center is going to be very different. And the equity of quality of access of care, we have many, many competent clinicians working in all parts of British Columbia. But to have access to, for example, specialty or even subspecialty, dermatology, vascular surgery, psychiatry, these different kinds of specialty, which usually tend to be centered around urban centers, how do we deliver those services in a rural location? And of course, at the end of the day, equity of care, it also leads to equity of health funding. And so how do we effectively fund and be cost effective in those? Those are the type of gaps that we see. But COVID changes everything. COVID exposed some of our challenge even more apparently. If you have a patient who has a COVID, and if he or she is in a rural community, in a First Nations community, and if in that community there's only 50 to 100 person, and if that patient infects, unfortunately, spread the disease to the health professionals in that community, you've knocked out the whole health system in that community. And so how do we look at those types of inequity? But also COVID gives us an opportunity. For example, this is a McKinsey & Company survey in the end of May. They look at in 2019, in terms of the use of virtual care or telehealth, as Dr. Lee talked about, it's about 1 in 10 patients experience telehealth in 2019, before the tipping point. But what COVID did was, by the end of May, we're looking at 3 out of 4 patients having the opportunity to experience telehealth. And also, if you look at the numbers, there's a 50 to 175 times increase in physicians using telehealth technology to deliver services. Huge change. It really tips, if you look at the Rogers curve, it really tips from the early adopters into mainstream. And I think that's what COVID has done for digital health. Same thing in Canada. Canadian Medical Association did a survey in June and found that, in fact, by the time of end of May, 1 in 2 Canadians have experienced at least one telehealth episode with their family doctors or with a doctor, either by telephone or by video or by text or by imagings and email. Is it okay? Are things projecting all right for me? Thank you. And so at the same time, for those who have experienced it, 91%, 9 out of 10 patients are very satisfied with using telehealth as a way to see physicians access healthcare. And so in that context, in British Columbia, we were also in March start to see a huge surge of patients who's very concerned about COVID, and our health system was getting ready to set that up. And so you can see on the right column, there's a group of us, including Ministry of Health, including Doctors of BC, which is Physician Services, Rural Coordination Center of British Columbia. I belong to the BC Emergency Health Medicine Network and the Faculty of Medicine. We work together to establish 8 lines of virtual care. And these lines, the map is a little bit complicated, but really it's divided in 2 parts. The top oval circle is how do we deliver service from health providers to patients. The bottom part is how do we provide peer-to-peer telehealth services. And so that's the first of 4 things I'd like to share with you about in emergency medicine in British Columbia. How have we leveraged COVID to achieve universal health care, at least closer to the asymptotes of universal health care? Let me describe the peer-to-peer first. In March, we started the organization. In April, we set up 2 lines, emergency care and intensive care. So that, as you see on the photograph, we use, for example, the digital iPads in the emergency departments. And then also we have consultants on the right screen that can come in through their own iPads or their own mobile phones. And we made a point that we do not use specialized equipment. We want to make sure that these equipments, for example, the hardware, and also, for example, the software, we use Zoom as our ability to do this connection. And also in terms of ultrasound, as best as we can, we use whatever available technology, and we do a choice of different kind of technology to do remote ultrasound so that we replicate the opportunity. So in case there's a patient with emergency at a particular rural part of British Columbia, that health professionals can reach out to a friend, an electronic friend, if you will, a peer, so that we can then join them in supporting the resuscitation of that particular patient and management. I work in Vancouver. Very fortunately, I get a chance in the emergency department. If I have a question about ECG, a chest X-ray, a CT scan, I can kind of go to my colleague and say, hey, what do you think about this image? Now with this virtual care, we have the ability within 2 minutes to call a colleague in the province to be able to do that. And so we started with emergency intensive care. We rapidly in July start to set up a telepediatrics service, followed in September in a maternal newborn care. And also since July to September, we've teed up pediatric mental health and also First Nations mental health. And then we're starting to have dermatology that started in May. And then we start to have rheumatology and hematology joining since August. And we now have continuing more lines so that at the end of the day, this is not about one line of service, but as we continue to expand, how do we look at these lines working together and integrate together for peer-to-peer experience in British Columbia to serve the type of geography that you see for us. If we turn our attention, so this is in end of June, just to show you some of the frequent spots that we're able to use this telehealth services throughout British Columbia. If we look at the patient to health professional contact, this example of the HealthLink BC. In British Columbia and across Canada and likely in Taiwan, there's a service called 811. So a patient can call, if they want an ambulance, they can call 911 and an ambulance come take them to hospital. But if they have a health question, they don't know how to get an answer, their family doctors may be close, that they have a 24/7 line called 811. They can call, and historically we have nurses there to answer questions, to say, you know, you need to go to hospital or not. But in March with COVID, the surge of the calls went up 7 to 8 times. And so the nurses at that particular time was very interested in partnership with physicians. And so we've been engaged, I've been engaged in supporting 811 in creating a HealthLink BC Emergency Doctors and Assistants, or HIDE. And so with that service, we started in April. You can see on the table on the right that people call in from all parts of the province. We have 5 geographic health authorities. You can see the numbers of distribution per 100,000 population is pretty even. Although, of course, you expect more calls from Vancouver by numbers, by absolute numbers. And since that time, we were able to partner with our nurses so that initially the nurse may recommend the patient to say, you need to go to emergency within 24 hours. But by having the opportunity of virtual physicians, we would see the patients, we'll start with a telephone call with them, but then we found that over time, we don't need every call to be on video. But in fact, 20% of the video, we absolutely need to go on video to actually see our patient. For example, a rash, a cut where it needs to be sutured, a pediatric patient that the parent either described as very active, but when you look at the screen, they're very morbidly sick, or the parent says the child is very sick, but when you look at it, they're jumping on a trampoline. So those are situations where video become a highly valuable tool for us. And with that, with the physician nurses working in partnership, we're able to reduce 7 out of 10 patients no longer need to go to emergency department within 24 hours. And this makes a difference in terms of preserving the emergency department for those patients who need it. Whereas for the rest, we can not only support them at home, but in an emotional level to support them so they don't feel anxious at home anymore. We can provide them with an access of care that they can feel equitable, that meets them, that supports them just in time. And we also found that 15% of the time, we actually accelerate them to go to hospital. Some people who thought they have indigestion, but turn out it's MI. So that may be an example. And we found that, again, just like the literature, 98% of patients feel very satisfied. So virtual care is one. Secondly, home health monitoring. For the last 4 years, we've been having a provincial research initiative thinking about for patients with heart failure. For example, for all of us, if we have heart failure, get admitted to the hospital, at the time of discharge, 1 in 4 of us in Canada will need to be readmitted to hospital within 1 month because of a heart failure episode again. And so what we're trying to do is we're trying to send patients home with blood pressure cuffs, with weight scale, with a pad, iPad, digital pad, so that they can answer question, how are you feeling today? We have remote nurses to monitor them, and we have a protocol. And by doing that, we also found that we were able to, in 3 regional hospitals, that we can found that there's a 59% reduction of readmissions and 44% reduction in emergency department visits, a 44% decrease in cost per patient, and also the patient have improved quality of life. As a researcher, I get excited about that. As a clinician, I get excited about what the patient says. This is the best I felt in 2 years. This is the longest I've stayed out of hospital. People who have not seen me for a while tell me what a difference I feel. And so we've embarked on a 21 community randomized controlled trial. We've just finished our trial recruitment and monitoring in April this year. And so we're in data analysis phase to demonstrate, hopefully, not only to see that benefits, but also to ensure, is there a difference or similarities if you're in rural community, urban or regional community? You use it differently in the context of universal healthcare. We're also very interested in big data. And for example, this paper, very fortunately got to work with our colleagues in Hong Kong, Stanford, and also in UK, looking at using machine learning to analyze data. In this case, these are 8,100 patients with high blood pressure. And we're looking at the blood pressure variability. The 2 numbers in between, do they vary a lot or very little? And by doing so, the historical way to analyze hypertension is looking at the quantiles, divide them into 4 equal parts, and then for the highest quantile, they do have more risk. And so in that case, in a classical way, it's about 33%. But we find that if by using machine learning, using a k-means protocol, that we can actually reduce that highest quantile to be 14%. So we stratify the patient better, and in that 14%, in fact, it reflects a higher correlation with stroke and heart failure risks. And so by using big data, we can now start to reanalyze the data that we already have, just like Dr. Lee said, to be able to start to predict, stratify, and actually manage patients. We're currently also embarking on atrial fibrillation in terms of predicting atrial fibrillation and whether success of therapy would be helpful. And so there's also a digital health underpinnings that's necessary. Of all these services, it's important that we deliver services, but how do we capture the electronic health record? How do we look at home health monitoring and also in public health and data analytics? And so my final slide is this, that as the emergency department, I work in an area of digital emergency medicine. And we're very interested in these 4 areas: real-time virtual support, virtual triage, home health monitoring as they go home, and finally, look at the data and how does that data influence how we treat patients in the emergency department. And so in many ways, I absolutely agree with what Dr. Lee talked about in terms of the 4 things that he talked about. Also, Dr. Kang, Professor Kang talking about the seniors care. And I think there are 4 areas of partnership, and then I'll wrap up. I think one is in British Columbia, we have this 5.1 million population. We have a collaboration with our Ministry of Health and the publicly health system. So if there are opportunities for clinical trials, I think our virtual care system may be one way that we can carry out certain type of clinical trials together. Secondly, if there are technology testing, again, this would be a good system, and I'm interested in emergency. So especially in the emergency home interface, if there are technology for testing, again, it'll be fantastic. The third is about big data. How do we leverage the data, AI, ML, so that we can actually be better at what we do today in clinical care? And finally, because we're working with Ministry of Health and senior health policymakers, how do we look at evidence-informed policy in digital health? As we create these evidence, how do we support our policymakers to make better policy? So at the end of the day, we can get closer and closer to achieve universal health coverage in a publicly funded system so that we can deliver equity of care for all. And so at the end of the day, it's not only about high tech, it's also about high touch. And then finally, I saw a recent video in Chinese, and that was a saying that really impacted me a lot. It says, 文明应该有温度. And so it's not only important that we look at technology, look at better services. At the end of the day, how can we serve our colleagues, our human beings, our patients better in a very caring way? Thank you very much for your attention.
You asked a lot of good questions, so we can discuss later. And also, the data that you share is so exciting. Now our moderator is online now. I will give this stage to Dr. Peter Chang. Dr. Peter Chang is president of the GTMA. He is an adjunct professor at Tufts University of the US. He was a former ombudsman of Taiwan. Currently, he is CEO of HealthCare Health Institute. Let's welcome Dr. Peter Chan.
Thank you, Professor Lilian Chu. And I'm sorry for my being late to join this moderation, but actually catch up all the presentation on the high-speed rail train from Taichung to Kaohsiung now, where I am in Kaohsiung. And I was able to catch up with Kendall's very interesting talk, as well as the Jack Lee and Jesse Kang. My job is simple, to introduce the next speaker, my old friend, Professor Jijin Hui. He's been working in Harvard University School of Public Health for many years. And most importantly, he has been a great success in setting up a Global Health Institute in Oregon. And particularly, he has been very, very busy in the last 10 months because he is really knowing Asia and North America very well. So without any ado, I would introduce and bring Dr. Chi to your attention. Professor Chi, please. Professor Chi,
yes,
you can speak now.
I'm trying to share my slide. So can everyone see my slide? Okay.
Yes, very well.
Okay, thank you. Thank you for Peter's introduction. It is a great pleasure for me to share my study, my knowledge with everyone. And I appreciate all the previous speakers' great presentation. And I will be taking from a very different angle for this topic. My expertise, as Peter already mentioned, my expertise is in global health and also in health system strengthening and finance. And so today, my talk will be focused primarily on the relationship between universal health system and pandemic control. And part of it, I will be using Taiwan as an example. So the motivation for this talk includes three main questions. One is, what are the nature and function of a national health system? And the other is, the second one is, what are the role of a national health system in pandemic control? And then the third question I ask is, what kind of national health system will serve the population health and well-being best for the future? And so my talk is divided into three parts. The first part, looking at the foundation of a national health system and its function. And then the second part, I will introduce how Taiwan, particularly NHI, performed during this pandemic. And then the last section will conclude with the future of national health systems. Let's look at the first part. So the nature of health system and its purpose. And the first part, I introduced the WHO's definition. What is a health system? That is a sum total of all the organization, institution, and resources. And their primary purpose is to improve health. In terms of the second question, what is the purpose of a health system? It's a very subjective questions, and it depends on the social value and consensus. So here, I list some of the examples. These are not a complete list, such as promote health, contribute to the gross national income, create jobs, and the last one, healthcare system as a social institution. So these are all possible purpose. And depending on how one sees that, the society will structure its health system in a very different way. And in terms of universal health system, there are political dimension and scientific dimension. So there's variation in health system, as we can imagine, in terms of value, particularly the distributed justice principles. In terms of goals that determine our functions and culture and norms and historical context also shape the goal of a national health system. So the political dimension is determine the value and goal. And for the scientific dimension is determine the method to realize value and goals. And all health system also grounded in certain framework, particularly ethical framework. And most universal health systems are grounded in communitarianism. At the same time, they are also competing with other ethical framework, ranging from capitalism, neoliberalism, etc. So the nature of health system, particularly its governance, can determine in a system who have access and who make most important decisions, and the distribution of financial burden and benefit, and the governance and structure, who make decisions, and finally, who is accountable. So on the next section, let's look at how Taiwan's national health insurance system performed during this pandemic. A very brief overview of Taiwan's national health insurance. It's a public finance with earmarked payroll tax. The delivery part is mostly private. The employer contribute between 30 to 50% of the premium, which is technically is an earmarked tax. So the structure of the system is very similar with that of Canada or Japan. And I'm not going to go over the detail, as many of you probably already familiar. This slide just for your reference about the characteristics of Taiwan's national health insurance. Last year, one magazine ranked Taiwan as the best in terms of affordability and quality, almost an outlier of all the international systems compared. During this pandemic, I summarized several important characteristics how Taiwan became very successful in pandemic control. First of all, is the healthcare system as an integral part of a national health system. So it's not just care, but the entire public health system as well. And this was first tested in 2003 SARS pandemic. And Taiwan learned a lot of lessons from that 2003 and dramatically improved. In a way, Taiwan is the only country that had 17 years prior to this pandemic to prepare it. And that also offered, this is not unique to Taiwan, many universal healthcare systems provide universal free testing, treatment, and with no financial barriers. And this is somewhat unique to Taiwan's, is it has an integrated health information system, particularly become very powerful and effective for contact tracing and for monitoring and for all the isolation and quarantine. And here are some statistics to summarize Taiwan's achievement. And then I have this comparison between US, Canada, and the other. South Korea considered other one relatively successful, and Taiwan. And take a look at the case fatality rate, case per million compared with US, Canada, South Korea, and deaths per million. And all consistently, Taiwan is an outlier of success. And this is from our world in data showing the economic impact and health impact. Again, Taiwan has the minimal impact, and here's the Canada. So one unique contribution in Taiwan's universal healthcare success, particularly in dealing with pandemic, is its information technology. And the NHI card is a smart card that play an important role for helping providers to identify the potential risk of the patient, as well as it's play a critical role for Taiwan's allocation of the surgical mask. Taiwan was the first country in the world to implement an universal access to surgical masks. And another system is an NHI medical system that also play instrumental role, particularly in early time in the pandemic, in identify which patient potentially is a high risk, particularly returning from overseas. And I mentioned earlier that both systems, the NHI card and the medical system, help Taiwan to distribute the universal access to surgical mask that is rationed at a very low price. And so no one has an excuse to say, I don't have access to surgical mask. And that makes it easy for Taiwan to mandate wearing surgical mask in all public indoor places and schools. And this is a more recent development for individuals to access their own health. And that also present a very helpful tool, information tool, for individuals to monitor their own health. So let's look at what's the future of national health system and what we can learn from Taiwan's success integrating its universal healthcare system and information technology in effectively controlling the pandemic. And this is a cartoon popular in the United States, looking at the profit as a motive for health system. And this is a 3 key tenet from WHO's objective of universal health coverage. Equity in access to health services, quality of health service should be good enough for everyone, and people should be protected against financial risk. And when we measure the success of a health system, there are different dimensions we need to ask. Particularly, we need to ask success in what dimension? To be in output or outcome in terms of improving health, but also improving the entire system so it can continue to improve health. And social equity is oftentimes a very important goal as well. And then the broader goal might be a better society for all. And there are common challenges in improving universal health system. The political dimension challenge in terms of solidarity and sharing capacity. How much individual and the society are willing to share. And then there's a challenge in equity efficiency. In terms of governance, who should make decision in what way? And then there's political imagination about the future. There's also technical challenge in terms of quality improvement for everyone, cost control, how to improve access, And the previous three speakers all address those issues and innovation, both in health technology as well as innovation in health information technology. And the nature of healthcare system, and I'm quoting one of my mentors, Professor Gavin, he argued we need to ask what sort of healthcare system, what system we as a community prefer. And that should be dictated by what sort of community would we prefer to live. And he argued that healthcare as the community commodity, not as a commercial commodity. So the lesson we learned from Taiwan can help us to develop a resilient health system for a resilient society. That includes Taiwan had 17 years to prepare its legal and institutional framework that few other countries are capable to do that within a short time. And also, Taiwan had 17 years since SARS to strengthen its health system, particularly in preparation for major pandemic like this one. Likewise, in the 17 years period, Taiwan strengthened its epidemic capacity building and innovation. Also, strengthen its leadership and advanced planning and deployment. And finally, Taiwan has also unique features, the society's attitude towards uncertainty of novel contagious diseases. In early June, Taiwan celebrated more than a month of zero new domestic cases. So Taiwan started to live in the post-pandemic mode domestically, but globally, no one can be isolated. But Taiwan shows us a glimpse of the future of what the post-pandemic world looks like. And as we look for herd immunity, Taiwan already demonstrated that before we have herd immunity, herd behavior is probably as critical as herd immunity. And the nation's pandemic control measure is as effective as its population's willingness to contribute their part. And that's conclude my presentation. Thank you very much.
Thank you so much for Professor G. It's a very interesting and the macro view of the global health and during this pandemic. If I may intervene a few sentences before I bring the microphone to the speakers and the audience. This is the 10th month. You know, actually, we are almost come to the turn of the baby, a newborn baby, that the world really having this 10 months old COVID-19 virus in the world. There are many physicians, medical practice profession over here. You know, 10 months really we can get a baby done and to a new life. But in healthcare profession, are we ready? Are we ready to having 10 months suffering and a lot of hard works, tremendous catastrophes, chaos in the global orders? Are we ready to bring up a new baby? And one of the opportunity is the ICT. Which is so important. I believe it's all the speakers cover about this ICTs, that we have a good data, we have a good transmission and communication of ICT, and we have developing the AI. And I appreciate all the speakers that bring these issues to our audience globally between Canada and Taiwan. And I appreciate that Professor Cho was so successful bringing all the important speakers to this panel. And so I would like to do further is to invite questions all common between the speakers that we can before we open to the audience. So I know, may I invite questions or comment between the speakers of this morning? I know Professor Kendall Hall already have a question. Would you like to address the question?
Absolutely. Thank you very much. Again, learning a lot from the different speakers. Really appreciate it. I was wondering with Professor Kang about the use of AI and the chatbots, and specifically the different languages that the chatbot may have. And then as you use the different languages, there are some common data that you can collect, but are there subtleties in the languages that you're not capturing? And how do you leverage AI to look at the cultural differences?
Thank you for the question. Actually, Drupal is dealing with the communication issues in the long-term care facilities starting from Taiwan. As you know, there's in Taiwan, the caregivers sometimes from other countries, a lot of people from Philippines, Vietnam, Indonesia. So in a long-term facility, 4 or 5 different languages are used in Taiwanese environments. So the language is a big issue. So that's the reason we have the interface of different languages. And then we look into the conversation or the writing, the nursing records. It's partially Chinese, partially English, and so we put into the training model in AI, and of course, different language require individual training, but the knowledge graph is exactly the same. So we use the same knowledge graph, which actually started from our research in National Taiwan University. We kind of organize or reorganize the textbook in nursing textbook, and we categorize all the kind of standard term into our system. So and then we build a knowledge graph. For example, if the temperature is too high, and what possible situation you may have, and what's possible action you need to do, and what's possible reaction. So this kind of knowledge graph we put in to the system, and then we train the model. The model is nothing more than understand what you're asking, and now the AI is super smart, that understand the meaning behind the sentences, and then we match the meaning, the structure we get, the meaning of the sentence we get, and matching to the knowledge graph, and then we know how we exact to answer. So that's the rough schedule, a rough procedure. There's 2 steps procedure, but the first step, of course, we need to have a real data, real language to analyze the details. And English is much easier because a lot of tools and also database. But Chinese, I don't think so. So we have the good database. And Vietnam, Indonesia, we can follow the same procedure, but the knowledge graph can be similar.
Thank you for JC. If I may ask Professor Jack Lee, I don't know Jack Lee is still online. Professor Jack Lee, you have been the leading in medical informatics for decades, and you are now presidency of the World Medical Informatics Association. I'm wondering these culture varieties. I don't mean the certainly including ICT accessibility around the world certainly is big. Between Canada and Taiwan, we probably do not have too much difference in terms of the capacity of using ICT. But if you look at around the world, and particularly COVID-19, Jack Lee, Professor Jack Lee, would you like to comment on how the world is overcome this disparity in terms of the ICT communication in healthcare? I'm wondering, is Jack Lee online?
Okay. Can you hear me now?
Yes, very well. Please, Jack Lee.
Okay. Yeah, somehow my WebEx video, but my video has disappeared. But anyway, I tried to turn it on, but it just wouldn't work. I tried to log out and log in again. But anyway, I think I just we did in my presentation, I did show 4 recommendations for the whole world to mobilize ICT to fight pandemic. The first one is AI, and a lot of our speakers, many of our speakers have talked about it. But in order to make the current form of AI, which is the most popular current form of AI, is called machine learning. In order to use machine learning, we need big data, good data. So the spirit is that we need to publish data, we need to show data, we need to share data, and of course, to the best expectation, we need to share data in a common format. There is a website. There are several major websites, worldwide effort to share COVID-19 data. One very famous website is called Kaggle, or Kaggle, Kaggle, and more than 20 COVID-19 patient data online. Although they're sharing it in a very different way, but it's a very good starting point. So once we start to share data, we start to we'll have the capacity to use AI to fight it. In terms of preventing it, in terms of creating the vaccination, and also creating the cure or the drugs for this new infectious disease, data, I think, is still the most important. But unfortunately, because of this international competition around creating, the speed to creating a vaccine or a drug, a cure, is of immense commercial value. For some of the bigger countries like the U.S. And China is infamous for their data quality and data sharing willingness. They're not really sharing or creating good data. Even India, and the most infamous will be Iran. They're not even sharing anything, or they share fake data, which is even worse. So I think if there is a lesson that we need to learn here, it's that, and COVID-19 is not the end of the story. We're gonna have COVID 2020 or 20, whatever. We're gonna have new infectious disease and a new type of health threat to human being that we're gonna face in the future. Not just this year. This is a bad year, but anyway, maybe there are even worse time in the future. So we need to start very early, and we need to create alliance. We need to work with each other to create the best data, international data repository possible.
Thank you, Jack. Even we couldn't see you on the video, but your address is very well received. We all hear very well. But I'd like to bring up another question that because between Canada and Taiwan, is there any particular issue regarding this the data sharing or data system? I mean, in healthcare system, is there some issue regarding government regulations or the real practice or industrial limitations that we would like to bring up to attention? Because we certainly would like to using this opportunity to enhance more collaboration between Canada and Taiwan. Both sides has a tremendous great leaders, health professional, grassroots or in the macro level. Do any of you would like to recommend something that to be considered in the future, to be implemented in the future? Or you are welcome.
Let me share my quick comments. Actually, the collaboration between health information technology, between Canada and Taiwan, go way back. The first project that I was involved was called PharmaNet, I think. PharmaNet, back in 2000, like 20 years ago, in Canada, there's the Health Infoway project. And actually, we sent a team of people from Taiwan to Canada to learn about PharmaNet, which is a network that connects all the medication information and prescription. Like it's like an e-prescription that we understand right now. But back then, it's still the network are very primitive, and the speed are slow, and the data format is not standardized. But we sent a team, and actually, also we also have some expert from Canada to help Taiwan to implement PharmaNet. And then it turns into Pharma Cloud. In Taiwan, now every doctor is using Pharma Cloud, and then we upgraded Pharma Cloud to or whatever cloud is, meaning now everybody can share in Taiwan every patient's data, no matter where the patient goes, even to a GP or to a different hospital. All the patient medications, lab data, and diagnosis, and now even images are all shareable across different institutions. So I guess that's something that we really can learn from. I mean, there's really a lot more that we can learn from each other. And we are also in Taiwan, we're creating something called a clinical data repository alliance. So several, like 20 hospitals are sharing their clinical data de-identified as research data repository. So I think if we can invite some of the university hospitals, major hospitals in Canada that's interested in doing a joint, collaborative alliance in terms of sharing research clinical data, it will be quite interesting because as you see, even the national health insurance data in Taiwan has enabled more than 1,000 papers a year, just that one database, and that's not even close to the electronic health record we have, right? It's an insurance claim data, and it's able to create more than 1,000 papers a year. So imagine the power of having all this clinical data repository, especially international, with Taiwan and Canada. So that would be a low-hanging fruit, the first item I would propose. Yeah, thank you.
Maybe I'll sorry.
Yes,
go ahead.
Chris. Yeah, Professor Kendall Ho, go ahead.
Yeah, thanks. Maybe I'll jump in with three thoughts quickly. One is British Columbia. There is a organization called PopData BC, POPDATA BC. What it's trying to do is to bring in all the governments, health authorities, and ministry health data together into one pot, so that for researchers, we can then go in with a certain type of credentials to be able to access and play within a certain secure environment. So I think PopData BC would be a very important strategy for us to think about that area. And then in Ontario, there's an equivalent system. It's called ISIS. And so again, in those two provinces, clearly there's a data strategy. Secondly, the lead of the PopData BC has recently got a national grant in, I think, $16 million to try to coordinate across Canada to figure out how do we do data sharing. That's going to take a little bit longer, but immediately, I think on looking at PopData BC or ISIS, that may be two strong possibilities to do so. One last thing, though, is this, that I think there is the clinical data, which is very helpful. And Dr. Lee certainly has hit on the PharmaNet, which is a very strong one in British Columbia in capturing community-based pharmacy medications. That's been going on for 20 years strong. But there's also the research grade type of data. And I think there are some intrinsic similarities and differences between the two. And so depending on the type of research we want to do, if it's about evidence-based policy translation, I think administrative data is very good. I think if we look at health services research, then clinical data married with research data is very good. But we're looking at diagnosis, especially accuracy of diagnosis, then really we're migrating towards a research grade data. And so again, trying to figure out where do we want to position ourselves will be very important piece.
I like to reflect that it's really inspiring that Jack Lee and Kendall, both of you, bring up those ongoing and very interesting development of programs. Maybe JC, you'd like to comment, adding some of your comments?
Thank you for the opportunity to say something that we focus a lot on data interoperation. So I mean, during the discussion, people focus. We in the discussion we focus a lot on how to integrate the data and how to exchange the data. But I want to say a little bit more about that. Probably in my past 2 years experiences, I put a lot of efforts on collect our own data with the wise way by designing the platform, designing the interface, so that people are using the system, and at the same time we collect the data. So by this method we get a pretty good results. We don't mess up the concept of have a big data and training like millions data set to get some results. That's one direction. But the other direction is if we have a 1,000 or 10,000 records, for example, the image with some labels or image with some sentences, and we put into the model, and usually we get a pretty good results. Let just give you several examples. One example is when I was in 2 years ago, I just joined University of Alberta, and we collect the data in construction sites, and I recruit like 10 different undergrad students. Their job is to collect 100 images and write the sentences, several sentences for the images every week. And with only one summers, we have a 10,000 images with all the label and description. And I put in the model and the trend, and the result is super, super good. And same in Jubal, we collect the data because we are running the platform, and we continuously getting the data from the users. And with 1,000 different images, with all the labeling, talking about the degree of the wound situation, the color, the size, and so on. And then we put it into AI training, and only 1,000 images get a pretty good results. I'm mentioning the chatbots. Maybe what it's good to focus some gigantic database, but to be honest, it's pretty difficult to deal with the data cleaning and the processing the data. It takes a lot of time. But thinking the other way without having any data, how to collect the data, how to use the machine to collect the data, how to use the machine to, when you collect data, you train the model. So that's the other way maybe we can think about from the other angle.
Thank you, JC. I really appreciate someone really working on the ground from Taiwan to Canada, both sides. But if I recall, earlier in 1995, when Taiwan's national health insurance was started, actually they was visiting the North American, USA first, then they visited Canada. And as I know, throughout 25 years, Canadian model for our development, our national health scheme and the informatics. But I would not need Dr. Junhui.
I tried to find out what happened. So we lost Peter right now. I see. I find someone write the question in the chat. Jesse, it seems that you have some question. Would you like to talk about your question?
Yeah, I see that Jack Lee. Jack, actually, Dr. Lee sent a question. Jack, can you elaborate a little bit the question, and you also provide some information about the
Yeah, right.
right?
Yes. As you can see, that Jesse proposed that we can probably share, without sharing the physical data, we can still train a good AI model, which is of course true. There is a you're muted.
Do you want to continue? We just lost. Okay, good.
I'm wondering, should Lillian continue, or can I put this question to Junhui Ji in Oregon? That if I can summarize, my question is that because in early times, Canada and Taiwan has very close collaboration on developing the healthcare system. But through almost 33 decades now, in terms of your comment on how Canada and Taiwan can develop further our partnership, and particularly during this pandemic.
Thank you, Peter, for the questions. For the last 2 decades, I have kept a very close relationship with the National Health Insurance Administration and served as its consultant or policy advisor on and off. And for the best of my knowledge, that collaboration had never stopped from the beginning. Even before we started the NHI in '95, Taiwan learned a lot from Canadian system, and then throughout those 2.5 decades, that collaboration has never been cut off. And in terms of the future, I think Taiwan, both countries has a lot to learn from each other, and especially for this pandemic, I think Taiwan can show Canada how the universal healthcare system can become a very integral and effective tool for pandemic control, which Canada seems isn't able to fully utilize its advantage of the universal healthcare system as well as its advanced information technology. And of course, there is also what I call a software difference. The hardware is all those information technology, but the software is the legal framework. And I believe not just Canada, most nations still lack that software that include both legal framework as well as social acceptance and culture in terms of how will people trust governments, particularly in time of emergency like a pandemic. How will people be willing to give up some of their privacy, such as personal information, personal mobility, personal locations? That is a vital tool for government's effectiveness of controlling the pandemic. And this came across many times in my media interview when I showed the media, both in the US and international journalists, how effective Taiwan has been using the information technology in contact tracing and in monitoring quarantine. They always ask this question: how can people accept that kind of intrusion of privacy? And I have to explain to them, Taiwan went through that debate for 17 years, which no country can catch up in such a few months. So I think that's the part Taiwan can share with Canada. And even though it's difficult to catch up in such a short time, but in preparation for the future, how a country can utilize its healthcare system together with its advanced information technology, not just in pandemic control, but in many other issues related to health and well-being. And that's just my comment.
Thank you, Junhui, for a very interesting response, because as an ombudsman, you know, the politician, we look at the government functioning very, very carefully, the governance. So it will be very interesting. I mean, in the future, we compare how Canada and Taiwan are doing this governance, particularly in terms of the healthcare governance. And it's between the public and private partnership, the trust between both sides, and how the industry, the private sectors, was serving these very much. Because I know that I do not have the data of Canada, but I know 70% of the health service has been provided by private sectors, like the one by Professor Jack Lee's institutions. So also JC Kang is doing another way of this private development of the healthcare. So I see that is very, very interesting. That I hope the discussion today will bring up a new idea and a plan that bring further the Canada-Taiwan partnership in terms of the healthcare assistance and healthcare service. I am wondering, do we take any question from the audience? Otherwise, I will bring the microphone to Lilian Cho in Canada. Do we have a burning questions from the audience, or we will leave to Lilian?
Okay. If you have a question, you can email me or text me. I will ask those experts to respond if we can. I'd like to close this forum. And first, I would like to thank you all for joining us online in this forum today. And I would like to thank our guests and organizers for their support. We actually received more than 100 people register for this event. So it come a lot from their help and support. I also like to give my thanks to our panelist, moderator, and our team. And I think it's worth to mention our team. Our team includes Justin Gao, Joseph Xie, Jenny Lin, and Liren Chu. Without them, the forum won't be accomplished successfully. We do a lot of work to marketing, to promote these events. We do a lot of work to prepare for, even though the connections still have some problem, but we do our best. So I really like to thank Joseph Xie. He spent all day yesterday to work on every details. And it is my pleasure to host this forum. I'm glad that we all agree that Taiwan and Canada can work together. And you know each other right now, so maybe you can start to make connection and develop some project in the future. And I'm very happy to support and to help the connection. And each country and each researcher know we all have strengths to support each other in many aspects. And in particular in artificial intelligence and digital technologies. And I'm sure together we will be able to cope with COVID-19. And a lot of people predict the COVID-19 will last longer than we expect. So the forum tonight was recorded, and we will post the link. And actually right now, a lot of people can watch the forum from outside, not from the WebEx. We also already make a film and recorded all the greeting videos. So when we finish, people can watch the video. And how do you find this recorded link for this forum? You can find it when you register. Joseph sent you a lot of link, so you can just click the link, then you will see the recorded forum. And we also will post the links in our Facebook, our websites, and also in the YouTube. Joseph also posts in Twitch and Periscope. I don't really know much about this too. So you can get all this information. Everything is recorded. And I hope you can share the link with your friends, your colleagues, and the world. Thank you.
Hi, I'm Don Davies, Member of Parliament for Vancouver Kingsway and Federal New Democratic Party health critic. It gives me great pleasure to bring warm greetings to the Canada-Taiwan Future Healthcare Forum. I know that universal healthcare is very important to the people of Taiwan as it is to the people of Canada. And I think it's no exaggeration to say that both Canada and Taiwan lead the world in our provision of universal healthcare services to our populations. I know with COVID, Taiwan has earned the respect and admiration of people all around the globe for the effective and efficient way that Taiwan was able to deal with the COVID pandemic. And we also know that the COVID-19 pandemic has also provided us with many opportunities to improve our systems of delivering healthcare. We know that virtual care, information technology, artificial intelligence, and other forms of advanced technology can accelerate the way that we deliver healthcare to our people and improve the care that our people get. So I would like to give my best wishes to all of you and wish all of you a very productive conference, and I look forward to greater cooperation between the people of Canada and Taiwan as we improve our healthcare systems for the 21st century.
Our gracious host, Dr. Lilian Chiu, panel speakers, ladies and gentlemen, it is my honor to address this webinar. I'd like to thank Global Taiwanese Medical Alliance for organizing such an invaluable conversation. Taiwan's COVID-19 response has earned near universal recognition and praise, but we still have much to learn from the experience of peers like Canada. Similarly, we believe that our Taiwan model can be shared with like-minded partners, and we are happy to work with Canada in this regard. We have much to gain through bilateral cooperation, but it is also imperative that we consider multilateral efforts And this is where Taiwan most needs Canada's help. In order to contribute to and benefit from global efforts to combat COVID-19 and improve public health, Taiwan must be included in WHO and other international organizations. Taiwan and Canada have much to celebrate together and much more to accomplish as friends and allies. With that, I look forward to listening to this expert discussion and also like to give my best wishes for this great event. Thank you.
Distinguished guests, ladies and gentlemen, good evening. On behalf of the Taipei Economic and Cultural Office in Vancouver, I would like to extend my warmest welcome to each one of you attending Canada-Taiwan Future HealthCare Forum, and also thank all our friends who have been helping promote relationship and exchanges between Taiwan and Canada. As the international community endeavors to strengthen mechanisms to combat COVID-19, Taiwan stands willing and able to collaborate with Canada in overcoming the pandemic. Taiwan will continue to take concrete and substantive measures to show that Taiwan can help and Taiwan is helping. I am confident we will have more partnerships in many areas to make our relationship even closer in the future. May each and every one of you enjoy excellent health, great fortune, and happiness. Thank you.
台大温哥华校友会邱会长、主持人、各位讲师、贵宾及朋友们，大家好！感谢邱会长筹办及邀请本人参加今天的论坛活动。受到武汉肺炎 COVID-19 的影响，保持社交距离、居家上班、远距医疗、居家照护等等议题，成为世人关注的议题。如何应用新科技在未来照护这些相关议题是我们今天的这个主轴。台湾政府和国民在这一波疫情的表现受到全球的瞩目和羡慕，加拿大的表现也非常的好。外贸协会结合台湾 PPE 等防疫抗疫产品的厂商，设立网络的台湾防疫国家馆，同时我们也举办了很多场次的防疫抗疫产品的发表会、研讨会，还有线上展览会及视讯采购洽谈会，协助台湾厂商来提供相关的产品给世界各国。预祝今天的论坛活动圆满成功，大家身体健康，万事如意，谢谢。
Hi, I'm Professor Peter Chang, the President of the Global Taiwanese Medical Alliance. On behalf of the GTMA, we are very pleased to invite you to join us in the coming Canada-Taiwan Future Healthcare Forum, which is going to focus on universal health coverage, COVID-19 pandemic, AI technology, digital healthcare, and the future partnership. As you know, that Canada-Taiwan join many things in common, and we are very proud to invite you to develop this program that we can share the expertise and the future innovative programs to benefit the development around the world. And I look forward very much to seeing you in these coming programs, and thank you so much for your attention.
大家好，我是台湾大学温哥华校友会会长邱丽莲。台大校友会很荣幸能够参加并且促成这次加台未来照护论坛，支持台大校友，促进国际学术交流和产业合作，是我们校友会的一贯宗旨。我预祝此次加台论坛大会成功。
各位贵宾，大家好！ 今天非常欣喜看到加台两地健康照护科技之专家、学者以及企业家们结合多方面的专业，一起为加拿大、台湾及全世界的公共卫生及全球健康做努力，提供现代化、科学化、数位科技化的合作机会。我们非常感谢这次参与论坛的专家学者们竭尽心力，一起为全球人民的健康做更有效的管理与护卫。我相信 Taiwan can help, Taiwan is helping。谢谢大家。
大家好，我是世界华人工商妇女气管协会会长周淑莲。今天非常开心能够和全球医卫总会、台大温哥华校友会以及加拿大国际结人会共同合办的人工智能、数位科技伙伴关系的加台合作论坛。这一次的论坛结合了加台两地非常优秀的专家、学者以及企业家，相信一定能够结合大家的力量，让两地健康照护的科技上更上一层楼，造福更多的朋友们，促进加台两之间呢更多的合作的机会。在此，我也祝福我们论坛圆满顺利成功，大家身体健康，万事如意。谢谢大家。